My name is Michael Fratkin. I am a father and a husband and a brother and a son, and I'm also what's called a palliative care doctor. And what palliative care doctors do is pretty simple. The first thing that we are good at is helping people with their symptoms. I've got a pretty good bag of tricks for pain and breathlessness and nausea and whatever, and I know how to use those tricks. The second thing we do is we help people and their families to navigate through what are sometimes very complicated medical situations, but what are always very hard medical situations. But I've come to discover that there are certain advantages to this magic window that we are all meeting each other through. Over the last year, I've discovered not only does it work, and not only does it have the obvious advantages that come from saving, well, we've estimated we've saved about 18,000 miles of driving for the people we care for. And you can translate in your own mind in a rural setting how many hours of their lives that translates in. We're clear that we've made life a little bit easier for people that have 100 to 150 visits to somebody else's site of care, somebody else's locus of control. So that part's easy. But what I've discovered with the technology is that there's a certain magic engagement that's not available in a three-dimensional space in a doctor's office. And there are even advantages for doing it this way over going to people's homes. There is a certain magical engagement. We can control the user experience by opening the window and closing it. That saves a lot of trouble in redesigning your waiting rooms, trying to keep your People magazine subscriptions up, and getting a good deal on cookie cutter artwork on the walls designed to try and make most people comfortable. Most people are most comfortable when they're people, and when by the time they walk through the door of any office, they become patients. And most people are uncomfortable with that role. So people in their homes have designed an environment to make them feel maximally comfortable. Or they've designed a chaotic environment that at least makes them feel maximally at home, right? By meeting them where they live and where they are in control of the encounter. And that adds a certain magical empowerment to who they are. I won't speculate about how much care will be done this way in the next 10 to 20 years, but a lot of care will be done this way, where it's not about the technology. It's about people, caring for people and doing what makes sense. And it sort of restores the tradition of a relationship with a human being in the context of their own life, identifying what their needs, desires, and priorities are, with a relational engagement that is now facilitated by mature technology. In other words, you and I are having communication, and if we're doing it right, the technology has disappeared. We're connecting. I'm able to monitor how you're listening. I can see if the nodding heads. And you can tell that I'm not bullshitting you, right? You can tell that I'm a real person bringing an experience to you. There's empathic engagement through the magic window. There's less distraction. And you're paying better attention to me than if I was sitting at the end of the table. It's true. And vice versa. But as it relates to the experience, not only is it pragmatically very useful to the people we serve, not only is it spectacularly more efficient, it actually works better for connecting people to people. And it's a very small proportion of people I need to go put my hands on, even for pretty sophisticated symptom control challenges. We are looking at medicine as if it must be what it has always been, but we're forgetting before it was what it is now, it was people taking care of people and doing what makes sense through engagement. David is about a 50-year-old fellow with about 38 years of heavy methamphetamine use, living in a trailer that has been evicted from the trailer park that he's living in. When I reestablished care with him, I went to the trailer, and you can barely stand being inside of it. And he is wildly disordered, but unlike a lot of long-term methamphetamine users, his heart remains available. He's touchable. And so my first visit to him, bringing a social worker with me, finding our way through a very tiny trailer with no running water, we engaged in trust again. I reestablished my relationship with him. I introduced him to someone I trust, my social worker, Nikki. I had to clean out the bottom of my shoe walking out of his house because he has a blind dog that doesn't make it outside. It's a terrible environment. And then subsequent follow-ups with him have been done sending our community health worker with an iPad in hand, or our nurse with an iPad in hand. We've connected our team to his primary care. By the way, he's got HIV, pulmonary fibrosis, and over the course of the last 9 months, he's had no hospitalizations. In the previous 9 months, he had 3 or 4 hospitalizations, one of which was 3 or 4 weeks in length. We talk about, well, we work through their defined Maslow's hierarchy. I mean, sometimes we talk about, what are you eating? Where are you going to the bathroom now that they unplugged your trailer? Sometimes we talk about his pain control, or what we might do to reduce the amount of smoking that he's doing. What are we going to do with his 22-year-old blind and incontinent dog? Those are the kinds of things that matter to him, and they translate into more appropriate utilization. I'm not telling you people anything you know, right? For your community-based mental health program, you know what I'm talking about. Sometimes the intervention that we do is I say, take your device, if they're on a phone or whatever, and take me to your refrigerator. Show me what you got in there. And sometimes that's the angle to understand how to create value by identifying the social determinants, right?
And
so sometimes it's that, sometimes it's typical, how are you taking your methadone? Why do you have more extra pills than you should? How many do you got in your jar? Show me your prescriptions. How are you taking them? Do we have your bowel regimen in place? All the basics that a geriatrician or a palliative care doctor do. We do whatever makes sense. Like I said, it's people taking care of people and doing what makes sense. It ain't rocket science.